So they asked me to talk about something I really enjoy, and that's the minimally invasive approach to mitral valve surgery. I actually started doing that in 1996 when the heart port, which a lot of people heard about, came out, and I was one of the first ones to kind of start doing that, and then we've developed since then. But minimally invasive surgery, there's some advantages, and these are the ones that most people hear. But most important, if you're going to do something that's different than what we're doing now, because we've been having excellent results with standard cardiac surgery, basically through the sternum, through the front, it has to be at least as good or better. If it's not, then just the fact of getting a smaller incision is not worth it, because we're talking about long-term life. We want to make sure the patient gets the most out of that valve and the longest out of that valve. So just to get a small incision, you don't want to sacrifice the effectiveness of the procedure. We do want to see pain decreased. That's an ideal thing. We're looking for shorter hospitalizations, especially the way medicine is going now. They seem to want to discharge you before you get admitted. And we want patients to recover quicker. Cosmetic I put in because my daughter is a nurse practitioner, and she said it's very important. I wasn't going to put it in, but we'll talk about that a little later. And then cost is a major issue, especially now. If you want to just decrease your incision a little bit, increase time, you don't want to break the bank doing it. And that's a real issue. So there's several ways of doing minimally invasive, and it's kind of progressed. The lower sternotomy is just a similar operation to what we do now, except you don't cut the bone entirely in half, you just cut partial, but you still do the same operation. It just makes it a little more difficult. You can go by the side and do it the same thing. But what we've gone to is a right lateral thoracotomy. It's actually going between the ribs and spreading the ribs slightly. What that allows you to do is get a direct vision right at the heart. So you can actually look through that hole and you're looking right at the side of the heart, and people think you want to do it on the left side, actually the right side, because you're looking at the top of the heart, and you can do your valve through that. And we started out just looking just like this, just looking at it, and then we started going to video assisted and then robotics, and that's brought several issues up. So the operation is based on what's called heart port technology, which was developed by Stanford and Hopkins back in 1996, by putting a bunch of different catheters in the heart to try to make up for opening the sternum and getting direct access to the heart. So what you ended up with a lot of balloons and catheters and wires that stuck in the heart to do the things I have to do to do surgery, which is stop the flow of the heart, cool the heart to protect it, open it up, and take over the duty of the heart and the lung. So it's quite a complex thing, but it can be done with these catheters. Unfortunately, getting these catheters in sometimes took hours, because you're all doing it with X-ray, fluorotype X-ray, so you have to try to find the hole. You can't really see it. And it really took a lot of time and effort, and some of them work better than others. So this developed into robotics. This is a friend of mine, Randy Chitwood at Eastern Carolina, who's doing robotics. In 1998, I'd been doing the heart port type technology, and I was in Leipzig, Germany, where Fred Moore, who's the one that started robotics, and Randy, who's sitting in that little table off the left, and I were there, and we were looking at it. Well, Randy was looking at something to put Eastern Carolina University on the map and to do his research, and he didn't have it, and he did it, and he's done a wonderful job with it. On the other hand, I was looking for something that I could use in a lot of patients. I realized this was not going to be it. Fred, in the first 15 cases, 7 died. It was a big learning curve. It was difficult to do, and this is minimally invasive, and there's nothing minimal about this operation. You can see all this stuff, and it's still, Randy's the only one that's not doing anything. The ones that are up there, all the surgeons and scrub nurses still have to be there. You still have to make incisions. You still have to have someone to feed the computer devices, and it takes a long time. So this is a shot of a minimally invasive robotic case, and it looks like they got hit with buckshot. They have holes all over their chest, because you have to have ports for all these little devices to go into. So there are limited. There's only certain procedures you can do. It's not easy to replace the valve. It's not easy to do a valve if they have leaky valve in the aortic position. It costs $1.5 million for the device, approximately $3,000 for every case in disposable equipment, and every 15 cases you have to change the arms, the 3 arms, at $25,000 a piece. So it's an expensive thing to use. Setup time takes usually 2 to 3 hours before the case can start. And then the learning curve Fred Moore feels it's about 100 cases, and Randy says 50 to 100, and 50 if you're an accomplished mitral surgeon, so it takes a long time. When you realize that the average surgeon in this country does less than 30 valves a year, half mitral, half aortic, it would take years to become competent with the robotic device, and some people never get there. Plus, you can't do a lot of the things I can do with the other device. So I saw this and we decided we probably ought to think of something else and didn't do it. Now these are the results that Randy's gotten, and I just use these as a comparison. Mortality rate for simple repairs, 2.5%. Our mortality rate for simple repairs, Vanderbilt, is 0. Using we're doing it. It takes about 3 times the time. An average robotic takes, in good hands, takes 7 to 8 hours. In new hands, takes up to 12. The case I'm going to tell you about takes me 3 hours to go in the operating room and out of the operating room. So the contraindications to doing port access. Well, if you have problems with the blood vessels in your legs, you can't get the devices up your leg. If the aorta is too large, you can't seal it so that you can use the balloon to stop blood flow to the heart. If the aortic valve leaks, you can't use it. If you've had a previous operation, you can't use it. If you have any other valve or coronary disease, you can't use it. So there's a lot of things that you can't do it. So it really limits the number of cases you can do, and you end up doing the rest of them some other way. So what we decided to do is change it. In 1998, we decided, let's see if we can simplify things. Because I'm a simple surgeon. I feel very strongly that the easiest operation, the simpler it is, the better it is, the more reproducible it is, the more you can teach it, and interestingly, the better the patients do. When it becomes very complex, a lot of things can happen and make the operation more difficult. So what we want to do is make it less difficult and more reproducible. So what we decided to do is get rid of all those balloons and devices, you'd say, and by no cross clamp, that means I don't stop the heart. What I do is I cool the heart and let it still fibrillate. It doesn't beat normally, but it beats. But it's still getting oxygen supply. And we found that if you decrease the body's temperature from 37 degrees centigrade, which is about what we normally are, down to 28 degrees centigrade, which I think is about 70, 80 degrees, then you can decrease the oxygen consumption of the heart muscle down to 5%. Which gives it good protection, actually more protection than if you stop the heart and try to keep it cold cardioplegia. So the heart actually gets more blood supply and more oxygen. And we also came up with ways of avoiding other problems, such as stroke, which is one of the problems when you don't clamp. But we found out if you give CO2 in the chest, which is heavier than air, CO2 is very quickly absorbed. So if it gets in the heart, it's not a big deal. They used to actually use it to do arteriograms before they had dye. So these are the things we did to try to change the operation. So what we do is a very small incision. That's the size of the incision, about 2 to 3 inches, on the right side of the chest, right about here. Then we put a non-disposable clamp, retractor in so I can look through that hole. And you can see about how big that hole is, 3 fingers, about that big. Then we cannulate the leg down here with perfusion cannula so I can go on the heart-lung machine, because I have to stop the heart and take the place of the lungs while I do the operations. We have a device that does that. It takes the blood out of the body, cools it, puts oxygen in it, and then returns it to the body. I designed some retractors. That's a retractor I designed to use so that I didn't have to make the extra holes you saw on the other ones, so you can all do it through one hole. And we designed that little suture holder. So everything's done through that one hole. That's the only hole you get. And that's just an operation with it, how we put the stitches in, bring them out, and then keep them organized, because if you don't, you've got a real problem, because you're down about that deep trying to work with these long shafted instruments. Those are the instruments used. That's all we use. That's a total instrument for that case. And they're called shafted instruments because the little things at the end, you squeeze them and it makes the jaws open and close. So you can look, a very small instrument go down through a deep hole, and I can work at the bottom of that hole. And that's basically what we're doing right there. I'm getting ready to tie a suture with this. It's called a knot tire. You actually push the knots down onto the heart. And that's doing a case. It's interesting. It's a one-man thing. You have one person. I have an assistant on the other side that holds the retractor, and I move it and just have him hold it, and he helps me then that way. So this is an operation. This is what I see. You're now looking through that hole at the heart, and it's still beating. You can see it beating there. That's the nerve that goes through the heart that makes your lungs work, your diaphragms work. So once we go on, we decompress the heart. I suck the blood out of the heart, so it's not, and I can open up the sac around your heart. It's called a pericardial sac, and everybody has one. And if we actually open that little sac, and then we see the heart. Now what I'm doing there is I'm dividing the tissue between the right side of the heart and the left side of the heart so that I can see the left atrium, which is where blood actually comes out of your lungs and then goes into the pumping chamber of the heart. That's it right there. Now what I want to do is I'm going to make a hole in that left atrium, and you'll see what happens in just a second. So now we're in the left atrium, and I put a sucker in there so I can see, and then make that incision a little bit larger. So we're now talking about, we'll have a heart incision in the heart about that big. And again, these are special instruments. You couldn't do this with regular instruments because you couldn't get them in the hole. And now I've put the retractor in, and that's a mitral valve that's got rheumatic disease, and it's all scarred down. And that one would have to be replaced, which would be hard to do with a robot, but I can do that very easily through this hole. And here I'm cutting that valve out. And then I'll put a new one in. So I changed it, and there should be another one coming up. Okay, now this is a different kind of thing. This is a valve where one of the little parachute cords broke that holds the valve in place, which is a difficult thing to fix. But through this, we can actually find where it broke. You can see where it broke off down there. And what I'm going to do is take a small Gore-Tex suture. It's Gore-Tex, just like they make out of your raincoats. But it's about maybe a little bigger than your hair, double the size of a hair. And I'll take that and I'll actually reach down inside the heart and suture it to that area where that little cord broke. And then once I get it down, attach that little tip, that muscle, it's called a papillary muscle. It's part of the inside of the left ventricular pumping chamber of your heart. And I'll use that to resuspend that valve. I'll actually go through the end of the valve, adjust the height of that valve so that it now matches the other side, and then I can test it, as we're going to do right there, and it works. And then all we do is put a little ring on the outside to maintain that structure. Sounds simple, but it takes a little bit of time. So this is just some of the patients we did. I'm now up to almost 3,000 of them. But what I'm showing here is that it's a platform that you can use for a lot of different operations, not just the mitral valve. We can work on the tricuspid valve. We can fix a hole in the heart, called the ASD, some people are born with, or patent framing. We can do a maze, so if people's in atrial fibrillation, I can freeze the nerves inside the heart and 90% of the time reverse atrial fibrillation. Tricuspid valves, the beauty about it though is if you had a previous operation, which really increases the risk of doing redo surgery 4 to 5 times or more. I've done patients that have had 5 big previous operations. And it's easy to do, and there's no bleeding. Bleeding is a big because of all the scar, because you're going in a virgin area making this very small hole. They do extremely well. And we can redo valves or anything we want through this thing. So it's a nice platform that you can do a lot of things with. Complications were interesting. Now these, I do the sickest of the sick with this because it's really easy to do it that way. And it's the only way we can do some of them. Our overall mortality is only 1.7%. Now, a redo mitral valve, CAB, has mortality about 10 to 15% across the board. A regular mitral valve has mortality about 5%. So it's an incredible decrease in that, and including patients are very high. And interesting, we still have no wound infections in almost 3,000 cases. This is by ejection fraction, that's how much your heart squeezes. A normal heart will squeeze about 60 to 70%. These hearts are really bad. They're called cardiomyopathies. 20% is less than 1/5 of the way that heart functions. Yet I can do those operations with these people with very low mortality, whereas we've not been able to do them before. And time. OR times means the time they go in the door to out the door. Under 4 hours on average. That includes multiple valves in that. Compare that to, say, robotics, which is 8 to 12 hours for a very simple valve in that. And a regular sternotomy for a redo normally takes 6 to 8 hours. We can still do them. I did one the other day in less than 2.5 hours. So it's very quick because there's small incisions. You don't have to take a lot of scar tissue down, and so it gives you better access and less bleeding complications. So what we did is we decided this would work so well that we have a hybrid room at Vanderbilt. Vanderbilt actually had the first hybrid in the United States, which very few people understand or realize. So what we do is we have an operating room and a cath lab in one room. So we can operate or cath, put in stents, dilate arteries, things that are commonly done simultaneously. So we thought, well, gosh, this mitral valve is doing so well this way. What if we take a patient that has a mitral valve and coronary artery disease, which is a big operation, has the highest mortality, and we take them in the operating room and we stent the coronaries, which is fairly straightforward, and then do the mitral minimally invasively. Does it really work better? So we did a group of patients, and the idea is that stenting is better than some saphenous veins, except for the mammary artery, which is down here, because we know that 95% of those will stay patent for 10 years. It's the golden vessel for us to use, and rarely will we stent the vessel on top of the heart. But if you have poor veins, or if we want to convert a high-risk operation to a lower-risk operation, does it work? So we took a group of patients, and there were some that just had valve procedures with coronary bypass, and others had re-operations and other things. A big mix of patients, but basically they needed a coronary done, and they needed a mitral done. So most of them were in their 70s, as high as 85, and most were male, because males tend to have more disease than females for some reason. And a big group of patients, but they were not easy patients. They were all fairly sick patients. And the cause was either unstable angina, means they were in the process of getting ready to have a heart attack, or actually had a heart attack. And others were patients that had sternotomy who wanted to avoid redoing a sternotomy. The types of stents, that's probably not of too much interest to you, but there's called bare metal, and there's called drug-eluting stents. Drug-eluting stents tend to last longer. The problem is they increase bleeding complications. So that was a real question for us. If we're going to operate on these patients, we're going to have to give them heparin, we're going to have to put them on heart line. Is that going to make a big difference? And doing the minimally invasive approach, it did not. So it allowed us to use coated stents with mitral surgery, which is difficult to do. And then the type of disease simply means ischemic, means it's because of the bypass of the coronary arteries or previous myocardial infarction. Myxomas is degenerate, and then rheumatic is rare now. SBE is infection on the valve. We did one of those as well. Most were just isolated mitral valves, but we did do some combinations. We did some tricuspids as well. And then again, our time was really good. The fibrillatory time, is the time it took to do the mitral valve, was only 1.5 hours. So we were able to actually do these patients and do the bypasses and the mitral valve in less than 5 hours. And we were pleased to see that the predicted mortality for this group was 9.6%, and the actual mortality was 2.6%. So we cut the mortality by almost 60%. So it worked. It rate is good. We do that now. 90% of our mitral valves at Vanderbilt are done this way now. I've taught a couple hundred people across the country how to do it, and they're doing more and more. It has a lot of advantages. So the conclusion is the hybrid mitral is a reasonable thing. We lowered the mortality, improved the operating time, and the patients did better. So minimally invasive mitral valve surgery, at least the way we're doing it, we're convinced it's as good or better than standard surgery. It's every bit as good, and in many cases it's actually better because we have less bleeding, less mortality. Pain was decreased, although it still hurts. Anytime you operate on someone and spread the ribs, it's going to hurt. So don't let people say it's not going to hurt. It is. Any operation is going to hurt. Complications were reduced. Patients recover quickly. Normally, if you have a standard surgical incision, it takes 12 weeks for the bone to heal. Now, you're up and around pretty quickly now, but still, you have to limit somewhat because the bone, if you get it loose, it'll never heal. So it takes longer, whereas this approach, 6 to 8 weeks, are pretty much back to normal activity. I operated on a surgeon not too long ago, did him on a Monday, he went back to full work the following Monday. I don't advise that, but that's what he did. Hospital stays were less. Cost is a really interesting thing. Remember how much the robotics cost? This actually costs less than doing it this old way, the standard way, because patients get out of the ICU quicker, it's a shorter operation, and it costs approximately $3,000 an hour to put someone in an operating room. People wonder why. Well, it costs electricity, lighting, but you've got eight people in there. You've got nurses, at least 3 to 4 physicians that are all getting paid. So it's very expensive to go to an operating room. So if you take five hours in the operating room, you know, you've got $15,000 just in keeping the operating room open. So it's an expensive thing to do. Now, cosmetics, I had to add that because my daughter said so. That's a patient after the surgery. The incision was 2 inches long. This is a picture of 2 men. One on the right is a young man that had a hole in his heart. The other gentleman is older, but gentleman mitral valve. But he's out about 3 months. He's just getting ready to go home, the one on the right. This young lady insisted on getting her picture taken. She had a mitral valve repair and an ASD closed 3 weeks before this picture was taken. And she was very happy with the results because they were talking about doing an incision down the center of her chest. So basically that's what we're doing. Technology is going so fast, it's unbelievable. And the proper use of technology really is beneficial to patients. And as I said, when we do these things, and we're doing them all the time, we have lots of studies going on. The first is the major premise I told you the first. It has to be as good or better than what we're already doing. If it's not, then you're not doing the patient a service, just to have a small incision. And even though the incision is 2 inches long, underneath it, the incision's about that long, because I have to open enough to get into it, and we have to operate on the heart. We still have to go on the heart-lung machine. We still have the risk of bleeding, infection, strokes, heart attacks, kidney failure. All those things can still happen. It is a big operation. There's nothing minimal about it. It's a minimal incision or minimal access operation, but it's a maximum life-threatening procedure and something you don't want to take lightly. Thank you. Yep. Now, I've got a hearing deficit, so I may have trouble hearing you, but go ahead.
This may not be fair to ask you. In your hybrid lab, are you doing the atrial fibrillation techniques there, or like this guy's?
They're what now? In the hybrid lab?
In the hybrid lab, are you doing the atrial fibrillation?
Yes. We're actually doing minimally invasive atrial fib right now as a combination with the cardiologists. We have the largest number of those in the world right now. Dr. Steve Hoff is primarily doing it. We do it several ways, through a small incision on each side of the chest, but now we're actually going with a scope underneath through the subxiphoid area, entering through an incision about this big, and Steve will do the cryo aspect or radio frequency ablation, and then the cardiologists go up through the vein and do the left heart side that they can't get at. And it takes a while. It's taken about 6 to 8 hours to do. So far, they've got 80 to 90% success rate with it, and they're doing well with it. That's for primary atrial fib.
Any redos on those?
And what now?
Any repeats? Because sometimes the ablation.
Let me get you. They do what now?
Do you have any redos?
Redos, you can't do that because you've got scarring. So they have to be able to actually get in the pericardial sac with no scarring. Now, if they're going to do a redo, they sometimes will do them through the side where they can dissect out, because then what they have to do is go around the pulmonary veins and do it from internal. But we can do total through the leg, which takes a long time and is not quite as good, about 70% results, or any of the combinations. And we have an atrial fib clinic where patients come in from all over right now to get that done. I've got a guy I'm going to do this afternoon that came in from Israel for me to do a mitral valve and atrial fib.
With such a small incision area, how do you approach teaching the technique?
That's the biggest problem we're dealing with right now. You know, because obviously we have to teach new surgeons. Excuse me? The question? The question is, what are we doing about teaching people how to do this? And that's a very good question, because I have trained surgeons coming to watch me frequently. And they watch what I'm doing, and then I get them set up. Now, they'll bring their perfusion at that to kind of learn, because you have to use special kinds of perfusion equipment and that kind of things that we use every day. And then occasionally I'll actually fly there with their first case and be there to help if it needs to be. The biggest question is our younger doctors who are learning how to do things, because you really have to know how to do mitral surgery before you can do mitral surgery through a small hole. So we're trying to do that, and there's less than 10% of our mitrals are only ones we do, and they're usually really bad, so there's not a good teaching case. So we've gone to simulation labs. We actually have developed sim labs, and we have one of the first ones in the country at Vanderbilt again, where we actually have animal hearts from slaughterhouses and places that we can put inside a human body, basically, that's artificial, and they can operate on those hearts. And we go over there weekly and work with them before we'll even consider letting them work with us. And we're also using more video. I wear a camera, which is what you saw. They wear a camera. So I can watch exactly what's going on. And you start out slow and you work your way up. But that's how I did it. And I'm very strong, because teaching people, they'd say, well, you've done your residency. Well, you're not ready to operate on people really that well when you're done your residency. So what I like to do is I like to keep the younger guys on as physicians. They have their own patients. They do the straightforward, simple cases, but when we get a hard case, we do them together. And that may take anywhere from 1 to 5 years. So learning how to do this stuff is a long process. 6 years after medical school, another 1 to 5 years on top of that. So you're talking about people really in training for after medical school, which means they're in their late 20s, early 30s. I started my practice when I was 36 years old. After all the training, I did a lot of research at Hopkins and that type of stuff. Yeah.
Is this procedure feasible medically and economically for bypass surgery?
They're looking at bypass. Actually, Fred tried to did some bypass surgery with the robot. It's okay, and some people can do it. He can do it. But still, what they do is they take the mammary artery down, and then they open the sternum and put it on. There's no real advantage. Now, we are doing more and more minimally invasive mitrals and hybrid again. I mentioned the mammary to the LAD. It's the single most important vessel you got. And that mammary, I see them patent 20 years later. It works so well. So you don't want to sacrifice that. So what we've been doing is doing a small incision on the left side of the chest, taking the mammary down, and we can put the mammary on the heart because it's sitting right here, the LAD is, and then stenting the rest. So we're looking at that right now, and it actually looks pretty good. So we can actually get a minimally invasive bypass as a hybrid case. Yeah.
When you did my mitral valve replacement and I asked you how, you told me you'd have to kill me if you...
What? It was funny, we were talking about my assistant at Vanderbilt. I've been operating this town for almost 30-some years, and have done about 12 to 15,000 cases, so I get a lot of yahoos like that. Yeah.
When children are born with these heart conditions, is there someone at the Children's Hospital doing this procedure?
Minimally invasive has not gotten to the kids yet. Although I've done some young children, some older children, because they don't do the minimally invasive mitral. I'm trying to encourage them to do that, because we could probably do ASDs, some of the valvular work that way, but it's the instrumentation would have to be completely redone. So we do it in teens. I've done several kids in their teens this way, but we haven't done the real small kids yet. Yeah.
How do you steady your hands?
What's that?
How do you keep your hands steady for 3 hours?
Stable? Steady? Well, so far I I don't drink any caffeine, and if you use things, instruments like that, you learn to 3-point contact. And that's why I try to teach residents. Don't try to sit up there and just do things. It's hard to do. Use the body and lean on. And if you support things, you can really get very steady. I've always liked working with my hands. That's what I've done, tying my own fishing fly, things like that. I think Bill Stoney comes here, he does the same thing. And yeah.
How bad does the AFib have to be before you decide for surgery? And how bad does the mitral valve have to be in order to decide for surgery?
Well, the AFib is easy. It has to be present, because the longer you let it sit, the harder it is to get rid of it. So, because what happens with AFib is as it progresses, the atrium starts to dilate, and the more the atrium dilates, the less likely you are to get a good result. So the earlier you catch it, the better. As far as the mitral is concerned, there are criteria we look at, but we're changing them all the time. If you look at the American College of Cardiology criteria, I would never wait till someone got that bad. They want to wait till the heart gets to a certain size, which is way bigger than I want. Now, Enrique Sereno, who I know well up at the Mayo Clinic, was real interested in this and actually looked at mitral valves. And we realized that that measurement doesn't mean a whole lot. What happens is once the heart, what we call the end systolic dimension, that's how big the heart is after it squeezes down. Normally it should be less than 4, and in most people about 3 to 3.5. Once it gets over 4, we can fix the mitral valve, but the long-term results aren't as good. More congestive failure, more rhythm disturbances, more problems with heart function. So now we're becoming much more aggressive. If I can repair the valve for certain, I'm very aggressive with repairing severe mitral regurgitation, which we can look at volume, how much leak is. For instance, every time the heart beats, say 100 cc's goes out the aorta, which is to your body. That's normal. But with mitral regurg, if it squeezes and 50 cc's goes back in the lungs and 50 cc's goes out, that's severe. And I would definitely fix that. 40, under 40, we watch if the patient's heart size isn't getting larger. So we follow them very closely. But I like to repair the valves if I can, although I don't hesitate to replace one, because data now coming out from Mayo Clinic is that repairs and replacements are just as good if you do them properly. Problem is a lot of replacements weren't. They weren't maintaining the under valve support, which is critical. And so there's a lot of variation in that, and we're trying to stop that. No.
What are the chances after bypass surgery that you'll need a valve replacement?
I don't know what the odds are, but they're different processes. I mean, bypass surgery is basically cholesterol buildup inside the vessels. Valve is degeneration. You can be born with a defect in your collagen, so it degenerates with time, which is myxomatous disease. You can have ischemic disease, where you have a bypass and you have a heart attack, causes the heart to dilate, which the little cords, like parachute cords, can be stretched, making it leak. Infection on the valve can make it leak. So a lot of different processes. And just getting older sometimes makes them get calcified, and then those valves have to be replaced. So at Vanderbilt right now, we do more valves than we do bypass, because we're just a referral center for that primarily. Yes.
What are the causes of valve disease to a young person?
Well, as I just mentioned, there's lots of them. There's heart attacks and ischemic changes. There's myxomatous changes, which is degeneration of tissue due to a collagen defect, some genetic defect you were born with, which we've been studying, trying to figure out which genes are responsible. There's infection on the valves. There's just aging of the valve and wear and tear. And the way the body heals wear and tear is it calcifies, and that makes it stiff so it can't move. And there's, you can rupture a valve, and it can just give loose. There's a lot of different things that can cause it. The most common now, it used to be rheumatic fever. Rheumatic fever was common. That's pretty well wiped out in this country. You still see it over in Africa and the Middle East and that, but you don't see it much in the United States. You see it occasionally in rural areas. Most of it is degenerative or just aging. And degenerative is what we see or most of now.
So a young person in their 20s that needs one of these.
The what now?
A young person, that, say in their 20s, like that young girl.
Yeah, well, some of them do. They have. You've heard of mitral valve prolapse?
Yeah.
Okay, that's not uncommon, and most of the time you don't have to do anything, but that is a genetic defect of the mitral valve where there's too much tissue. And there's another one called Barlow's valve, which just has lots and lots of tissue. We see a few of those in younger people. But, you know, nothing's perfect, unfortunately, and we have to try to correct it as best we can. But we can't make it as good as the maker did, that's for sure. Yeah. Yeah.
You mentioned that the OR charges $3,000 per hour for just keeping it open. Can you give a general range of what a procedure like this would cost, including surgeon's fees, rehab?
Yeah. It's changed a little bit. It's around 50 grand to 70,000 probably when you total everything up. Lab costs and that. When I'm saying it's 2,500 to 3,000, that's what it costs the hospital. Now they don't want to they're going to charge. They charge all different kinds of things, but that's all regulated by reimbursement rates now, which have changed. The average profit on one of these things for the hospital is only a couple $1,000, $2,000 to $3,000. They don't make a lot of profit off that, and some of them they lose on. And we're trying to look at that because obviously the profit for a hospital like Vanderbilt goes into education and to buying new equipment for all this research. So if the profit gets too low, then we have to cut back on some of those other things, which we've already cut back enough. For instance, when I trained, there were 140 different training slots in the United States for cardiac surgery. For every slot, several hundred applied. Last year, we're down to 72 training programs because they closed 70 of them, and there were 36 U.S. graduates applying. The average age for cardiac surgeon right now is 57. That means we're not keeping up. In 5 to 8 years, we're going to be really short on cardiac surgeons. People like me, who's older, is going to be retired by then. I'm going to be retired by then. We went from 4,800 down to under 3,000, I believe, right now. And we anticipate another half of that in the next 10 years, unless we increase our training. So it's an issue.
Are you getting the same quality of medical students?
The medical students are all very smart. They don't get there without doing that. But they're looking at a lot of, I don't know if we should talk politics, but a lot of things that are going on now in medicine is discouraging them from going into higher risk fields. For instance, Pennsylvania has no OB doctors. They're all midwives. They quit doing that because the liability was so expensive that the insurance cost them more than they made. So it's hard to find an OB doctor in Pennsylvania. Florida, you cannot find a neurosurgeon in the ER. They won't go. It's too expensive. The malpractice is too high. So those issues have to be dealt with. But if you say I did 9 years of training after medical school. Well, a young smart medical, he can finish, he can go in and be a dermatologist or a plastic surgeon or an anesthesiologist and make more than I make in 3 years. It's a big difference.
Bring the body temperature from
What now?
37, you bring the body temperature from 37 to 28.
28 degrees centigrade.
Okay. Were there any other effects on other body organs than?
Well, all the organs basically are preserved more. They start getting, less and less urine. For instance, if I have to replace your main blood vessel up into your arch where the blood vessel come off the brain, I do that frequently because that's one of the things I do here. I'll cool you down to 16 degrees. And at 16 degrees, I can shut off all the perfusion to your body and your brain for 30 minutes. Now, it gives me 30 minutes to do the operation because then I've got to resume flow. But that's what I do. I do the chronic embolic and things like that. That's how I do it. But I just shut the pump off, drain your body of blood, operate in a nice dry field, do as quickly and sew it back up and put the blood back in.
Very little infusion or no perfusion at all to the brain for 30 minutes. 30
minutes at 16 degrees, 16 to 18 degrees. You can't do that. Well, I do it all the time, and we haven't had too much effect. Actually, some of the wives think they're a lot more pleasant. Any other questions? Yeah.
For the people who have AFib, would you suggest that we talk to our cardiologist about?
Now, AFib's an interesting. It is the most common problem in cardiology after the age of 60 is atrial fibrillation. 20 to 30% of people will get it before they die. The problem with atrial fib, it does several things. It decreases the efficiency of your heart by about 20 to 30%. It increases the risk of stroke substantially. And it makes you just feel bad, because what happens, your heart rate becomes irregular, and it can go real slow or real fast. And you do what we call simonia. Your blood pressure is going up and down like this. It just makes you feel bad. It decreases your ability. So atrial fib is an interesting problem. And we spend a lot of time. We have several people that's all they do is study atrial fib, trying to see how we can either reverse it or how we can stabilize it. Now, we know that if I go in, for instance, and I do a mitral valve, there's a thing called the left atrial appendage, which is the ear of the atrium. 90% of strokes in atrial fib come from that area because it collects clots. So when I go in and do an operation, I actually close it with a suture, with a very fine suture, so that it's nice and smooth. And that decreases the risk of stroke, even if you're in atrial fib. So there are a lot of things you can do.
Is atrial flutter less?
Atrial flutter is a little different. It comes from a different focus, primarily in either the left or right side, but that's where the atrium is beating at a high rate, but it's not irregular. It's a regular rate, and then you can have various block. It's one of the harder rhythms to treat as far as medically, but it many times is one of the easiest ones to treat with EP. And sometimes when I do a maze, for instance, for atrial fib, they'll go into atrial flutter, and I'll just send them over to the EP guys, and they'll find a flutter, but they can now map it, find it, they zap it, it's gone. Yep.
In treating the flurry, would you explain to us what the ablation means?
Ablation simply means you're damaging the nerve that's causing the problem. Atrial fib mostly comes out, there are veins coming out of your lungs that feed the blood back into the left atrium. Majority of atrial fib develops in these veins. So we learned that if you can block the nervous impulse from inside the vein to inside the atrium, you can stop a significant amount of atrial fib. So part of the maze procedure is I use cryo. I freeze it to minus 120 degrees for 2 minutes in a little strip, and that basically kills the nerve cells. And I'll make a strip around those pulmonary veins, and then in various other areas, thus blocking those signals. And that's how we do it. Now, you can do it with several ways. You can do it with freezing, which I like to use because it has less risk to other surrounding tissue. Radio frequency, which burns it. Using radio frequency device can actually burn the nerve. And microwave has been used. So all three different energy sources, they all work. And radio frequency is faster than freezing, but I like freezing because it has less risk of damaging, say, the esophagus and other things that are around.
Does that take care of the problem, or does it recur?
It depends. As I said, nothing's perfect. So the longer you have the atrial fib, the less likely it is going to last. If you've had atrial fib for a long time, and you do it, say, through the leg without opening the chest, 50 to 60% will work. Many of them still have to have medications on top of it, but some don't. If you open the chest and do it, about 70% will work. And if you've been in what we call paroxysmal atrial fib, you're just getting atrial fib, about 90 to 95% of the time it'll work. Yeah. You may have to Okay, I can't hear you, unfortunately. That's part of me getting old. When I was a kid, I was raised in New Mexico. And for fun, we went out and shot guns. And you weren't a man if you had to wear ear protection. Now I'm paying the price.
She wants to know if she should take her husband to the doctor. He was in AFib for an hour last night.
Yeah. I think if you're having intermittent atrial fib, I think that the various people, the emphasis is changing. Now, you got to understand, I mean, the routine treatment for atrial fib was put John Coumadin and control the rate. And that works, but we now know that we can actually make patients better, and if they're just going in and out of atrial fib, those are the most likely that we can actually fix. And so and we have a clinic, atrial fib clinic, that looks at all these patients, but you have to look at a lot of things. First of all, mitral insufficiency, leaky mitral valve, can cause atrial fib and cause the heart to dilate. So you have to work them up. You have to look at all the different things to figure out what's causing their atrial fib. Because more than likely, as you get older, atrial fib is a result of some other problem. Whether it be a previous MI, whether it be a valvular disease, there are other things. You have to find those things because you have to fix those first, or in conjunction with atrial fib. Younger people with atrial fib, it's not uncommon to have it isolated and nothing wrong with the valves, and those are other ways of fixing it. It's a whole bunch of different types of things, but you have to evaluate each patient individually.
Yes, when you place a stent in a patient, what are the stents made of? How long are they? And
they vary in length. They're made out of different alloys, and then they have different types of, the drug leads have different types of things coated on them. They're extremely small. You think your coronary arteries are about, some of them about the size of a lead in a lead pencil, others about twice that size. They're very small. They fit onto a catheter, and we have them from short ones to long ones. And many times they'll put 2 or 3 in a row, depending on how much they have to stent. The guy that actually started this whole thing was a guy named Alon Grunzig. He was down at Emory, and actually he was from Sweden, but he learned how to dilate arteries back. The first time I saw it was, back in the 70s. And then people have just advanced. The stents work quite well. They're not perfect, but they work well and they're easy to use. Bypass surgery, in general, works a little better, particularly for the mammal to the LAD. So you have to look at the vessel that's involved, the patient, what kind of condition he's in, whether he has good usable veins and a usable artery. A lot of factors go into it, but it's not just one thing or the other. It has to be, you have to figure out which one's best.
Dr. Basic, 5 years ago, I thank you for replacing my aortic valve. This is my opportunity to publicly thank him for fixing my engine.
Thank you. Yes, sir.
One more question, and then we'll have to be done. If during a heart echo procedure, they talk about making bubbles,
Right.
did I understand correctly that is a valve malfunction?
No, what they use bubbles for is to check to see if there's a shunt from the right side of the heart to the left side through a small hole in the atrial septum called a PFO or P. And what they do is they make micro bubbles, extremely small, and they inject it in some blood, and then you see if the bubbles go from the right heart to the left heart, which they're not supposed to do. And that just tells you there's a hole in your heart. Now, the problem with a hole in your heart is that, number one, it can increase the risk of migraine headaches in younger people. The second thing it can do is it can cause strokes. Because say you get a blood clot in your leg, and a small one goes up to your heart, and you gasp at that time, which increases the pressure on the right side, it can shoot across that hole. Then it's in your arterial circulation, which the direct shot is right up to the head. So a lot of times, if a patient has what we call a TIA, they get dizzy or blurred vision. We give them one, then we put them on Coumadin. If they have another one and they have a PFO, we close it.
Thank you so very